Hello, this is Dr. Eric Bricker, and thank you for watching A Healthcare Z. Today's topic is, do America's medical schools want value-based care? Well, the answer is it's complicated. So here we have the School of Medicine here in the middle. It could be the University of Michigan. It could be a private university like Johns Hopkins, where I did my residency. And that School of Medicine gets money from a variety of places. It gets money from the endowment. It gets money from grants. It gets money from the overall university. It gets money from the government. It could be the state government in the case of a state university medical school. It gets money from tuition for people paying to go to medical school from the students. And then you have these two huge blocks down here. So the School of Medicine actually gets money from the health system, from the hospital system, the academic medical center, if you will. And that academic health system, if you will, is filled with multiple hospitals, plus it has the outpatient clinics, plus it has ambulatory surgery centers, plus it typically has home health. Oftentimes it even has a health plan, like the University of Pittsburgh Medical Center has a huge health plan. You can get Medicare Advantage through it. You can get UPMC health insurance through your job. So some academic health systems have health plans. And then you have the entire faculty, all the physicians over here. And I made a whole bunch of different columns because each individual department, they get to keep what they bill, right? So it's not really one physician practice, it's a whole bunch of individual physician practices. It's the Department of Surgery, it's orthopedics, it's cardiology, it's oncology, it's OBGYN, it's pediatrics, it's urology, and the list goes on and on. Now, the hospital takes the facility fees that they receive and they give some of that money to the School of Medicine. But the faculty give money to the School of Medicine as well, and it has a horrible name. Guess what it's called? It's called the Dean's Tax. So all the faculty have to pay a tax to the dean. As you can imagine, the faculty don't like paying a tax to the dean. It ends up being, typically it's about 10% right off the top to go to the School of Medicine. But what has happened is that over time, the hospital system has been able to demand higher and higher reimbursement rates from Blue Cross United, Cigna, Aetna for the commercially insured folks from their employer-sponsored plans. So the hospital system has been getting more money on this side. Meanwhile, the physician reimbursement has been going down. Reimbursement from Medicare is actually lower than it used to be. And a lot of commercial insurance reimbursement is based on Medicare reimbursement. So as Medicare reimbursement goes down, the commercial insurance professional fees go down as well. So the doctors are getting sort of doubly squeezed. And believe it or not, the typical physician actually loses $228,000 a year. It takes a School of Medicine an extra $228,000 to pay for one of their faculty because they don't bring in enough money in their billing. So where does the money come from? Well, some of the money comes from the hospital system actually pays subsidies to the doctors in order to maintain them. Okay, so this is a complicated web of financial money movement. Now, what happens when you add value-based care, in other words, taking on risk, in other words, capitation to this model? Well, that totally changes where the money flows here, right? Because in value-based setting, by definition, you want the hospitalizations to go down. So the hospitals are going to make less money. Whereas you want people to have more outpatient care. So the amount of budget for the clinics is going to go up. Same thing for ASCs is going to go up. Home health is probably going to go up because you're going to deliver more care at home and less in the hospital. And then the health plan itself, to the extent that it's successful, it's going to have a lot more money, right? Because it's not paying out as much for the care and it's able to keep the difference between what the capitated payments are and the less care that's going out. And then on the physician side, these physicians, especially the specialists, they're going to be bringing in less revenue because, again, by definition, you're going to be treating people in advance, preventing disease. So they're going to do less surgeries, they're going to do less orthopedic care, they're going to do less cardiac care, et cetera, et cetera. So the overall physician reimbursement is going to go down. So in other words, the School of Medicine's Dean's Tax is going to go down. So if you keep the existing financial relationships in an academic medical center and in a School of Medicine the way they are today, there's going to be a tremendous amount of resistance against value-based care, against risk, against capitation. Okay, now, the AAMC, which is the trade association, the American Association of America's Medical Colleges, they actually have a fantastic white paper about what to do about these financial arrangements. And one of the main suggestions from the AAMC is to change the compensation model for the physicians. Okay, so in other words, the value-based care in an academic setting is not going to change unless you have much more of a subsidy going from the hospital system over to these specialists to make up for their decreased billing that they're going to do. And And you're going to have to change, you're going to have less money going from the dean's tax over to the School of Medicine. So the hospital system is going to have to jack more money over to the School of Medicine as well, coming from the health plan. And guess what? That's exactly what Ochsner did. Down in New Orleans, they took more money from the hospital system side and they increased the subsidy over to the physicians, and they actually put them on salary and off the RVU treadmill. So in other words, the specialists are like billing less than they used to, but their income is staying the same. They even paid them more. They said, look, for doing less, we're going to pay you more. Because they were doing so much more home health and outpatient surgery and stuff in the clinics and not in the hospital, that they were saving so much money on the difference between the clinical care and the capitation payments that they were getting, that they were able to use that money to even more greatly subsidize the physicians. So just know that, like, if you don't change the way this money flows within a highly complex school of medicine, then you're never going to change the adoption of value-based care. So really, the answer to the question of do America's medical schools want value-based care, like, the answer to that is political. Do America's schools of medicine have the political will to make that change? I don't know. We'll see. And thank you for watching A Healthcare Z.